Every implant surgeon has seen it. A case that should have healed doesn't. Perfect planning, clean execution, great torque, beautiful graft. And yet, weeks later, the biology tells a different story. Why? Most failures don't start in the drill, they don't start in the implant design, they don't even start in the graft material. They start in the environment, in an invisible biochemical storm that quietly dictates whether bone forms or disappears. That storm is oxidative stress. It delays osseointegration, it suffocates grafts, it destabilizes soft tissue, and it does all of this silently while the surgeon thinks everything's fine. But here's the uncomfortable truth. You either enter a high oxidative stress environment or you create one. Sometimes both. Today, we're going to expose that hidden force and show you how to control it. After 30 years in surgery, I've learned one brutal truth. Biology always wins. On this channel, we don't just talk about implants and grafts. We study how the body fights back, how we can work with it instead of against it, what the evidence actually shows, and how disciplined surgical systems turn chaos into predictable outcomes. Welcome back. Today, we're diving into oxidative stress. What oxidative stress really is. Forget the slogan, free radicals are bad. That's not helpful. Oxidative stress is the moment when reactive oxygen species, ROS, outnumber the systems designed to control them. Every incision, every osteotomy, every graft. They all trigger ROS by design, to sterilize, to signal, to attract cells, to kickstart angiogenesis. ROS are not the villain until they are. When ROS are excessive and prolonged, osteoblasts slow down, angiogenesis drags, fibroblasts struggle, collagen breaks down, osteoclasts gain the upper hand. Healing doesn't fail overnight, it just never fully takes off. And this is the key point. Implants and grafts don't fail in isolation, the environment fails. Osseointegration loses momentum. Osteoblast precursors don't mature properly in a high ROS environment. You still see torque and ISQ, but biologic stability is weaker, slower, less certain. Angiogenesis suffocates. Endothelial cells under oxidative pressure don't form and remodel vessels properly. Microcirculation stalls. Grafts don't receive blood fast enough. By the time a perfusion improves, the early window is gone. Bone resorption quietly accelerates. Oxidative stress biases bone metabolism towards osteoclast activity. Crestal bone loss is often not a mechanical problem, it's an oxidative biology problem. Soft tissue stops protecting you. Collagen is degraded. Fibroblasts are compromised. The mucosal barrier becomes fragile, inflamed, and unstable. Recession, redness, that unhappy tissue around implants and grafts, this is where it starts. Grafts lose their future. Hypoxia plus ROS in a grafted site leads to partial integration, fibrous encapsulation, volume loss, and irregular contours. The graft material didn't simply resorb, it never had the environment it needed to become bone. Oxidative stress does not begin when you pick up a drill. It begins long before the patient sits in your chair, and it escalates with what you do in surgery. Systemic sources, the storm the patient brings in. Think about this list as a biologic risk map. Diabetes, smoking, obesity, cardiovascular and metabolic disease, chronic inflammatory conditions, vitamin D deficiency, high stress, poor sleep, ultra-processed low nutrient diet, sedentary behavior, lack of structured exercise, metabolic inflexibility, constant grazing, no fasting, and, in modern life, mitochondrial dysfunction from lack of natural light and no near-infrared exposure. Each of these increases baseline ROS, weakens endothelial function, slows angiogenesis, and compromises bone and soft tissue repair. Exercise. Regular movement isn't lifestyle advice, it is vascular preparation. It improves endothelial nitric oxide, boosts mitochondrial resilience, reduces chronic inflammation, and improves microcirculation. In other words, better scaffolding for graft and implant healing. Intermittent fasting. Even a simple 12-14 hour overnight fast lowers inflammatory signaling, improves insulin sensitivity, improves metabolic flexibility, and enhances autophagy and repair. Less oxidative noise, more biological bandwidth to heal. Near-infrared light, which is 810 to 830 nanometers, interacts with cytochrome C oxidase in mitochondria. It leads to increased ATP, reduced ROS leakage, improved nitric oxide signaling, enhanced microcirculation, more efficient angiogenesis, and better fibroblast and osteoblast function. For high-risk metabolically compromised patients, near-infrared light is not biohacking, it's a way of resetting mitochondrial reality before and after surgery. The point is simple. Many patients walk into surgery already oxidatively stressed. Surgical resources, the storms we create. Now we look in the mirror. Heat. High drill pressure, dull drills, poor irrigation. Bone overheats, cell die. Local ROS spike massively. You don't see it on the day, you see it in the healing. Traumatic flap handling, rough reflection, overstretching, aggressive retraction. Perfusion collapses, tissue goes hypoxic. Hypoxia drives ROS. ROS damage the very flaps we rely on to protect the graft and implant. Tension and compression. Tight closures look neat. Biologically, they are strangulation. Compressed tissue equals no perfusion, equals hypoxia, which leads to ROS surge. Over grafts and membranes, this is one of the fastest ways to compromise outcomes. Dead space. Any void under a membrane or above a graft is not just space, it is a pocket of hypoxia. Hypoxia leads to ROS, which leads to delayed or failed angiogenesis. The graft beneath that dead space simply never gets the vascular support it needs. Biomaterials that suffocate. Low porosity, poorly interconnected grafts slow down vascular penetration, extend the hypoxic phase, raise oxidative stress in the healing volume. Same surgeon, same protocol, different graft microarchitecture, different biology. Unstable graft granules under muscular activity. This is one of the least discussed biologic failures. When graft granules are not stabilized, lips, cheeks, tongue, floor of the mouth muscles are constantly micro-moving that graft. Micro-movement shreds the early fibrin scaffolds, tears fragile neoangiogenic vessels, disrupt early fibrous tissue organization. The result: more hypoxia, more oxidative stress, partial graft collapse, fibrous encapsulation, unpredictable contours. Stability is not a nice to have detail, it's an angiogenic prerequisite. So far, we've stabilized two hard truths. Many patients arrive in a biologically hostile, high oxidative stress state. Many surgeons unintentionally amplify that state with heat, tension, dead space, poor graft choice, and unstable granules. The good news? Oxidative stress is not random. It is manageable if you treat it as a surgical variable, not background noise. Now we turn this into a system. Identify the high ROS patient. You know this patient: smoker or ex-smoker, diabetic or pre-diabetic, metabolic syndrome, chronic inflammatory disease, poor sleep, high stress, sedentary, processed diet, constant snacking, thin phenotype, history of slow healing or complications, no exercise, no fasting, no light exposure. These patients are biologically different. They need a different plan. Reduce ROS during surgery. Make each step a biologic decision. Use room temperature irrigation. Avoid drill pressure. Use sharp, efficient drills. Keep osteotomy time controlled. Design and reflect atraumatic flaps. Preserve and restore perfusion. Achieve true flap passivity. Avoid compression sutures. Eliminate dead space and fully stabilize all graft granules. Every action either lowers oxidative load or increases it. Support angiogenesis. Healing is vascular. If vessels fail, everything fails. So keep operating time efficient. Avoid bone dry fields. Use PRF to support early biologic signaling when appropriate. Select high porosity interconnected grafts. Ensure tension-free stable closure. You're not just placing materials, you're engineering a vascular environment. Fix the patient's environment. The surgical month. This is where we shift from technician to surgeon. For 2 to 4 weeks around surgery, correct vitamin D where possible, reduce or stop smoking, reduce alcohol, improve sleep hygiene, simplify diet towards anti-inflammatory, nutrient-dense foods, use a 12-14 hour overnight fast window, avoid constant grazing, get them walking daily, add basic strength work if realistic, consider near-infrared light therapy 3 to 5 times per week preoperatively and in the early postoperative period. Near-infrared light reduces oxidative stress, improves mitochondrial function, enhances microcirculation, accelerates soft tissue and graft healing. This is not wellness for its own sake. This is surgical preparation for a biologic procedure. Oxidative stress is not an abstract biochemical concept. It is a daily practical factor that decides whether your implants integrate, whether your grafts vascularize, and whether your soft tissues stay stable. When you ignore it, you see mysterious crestal bone loss, grafts that never quite become what you planned, and tissues that always look slightly unhealthy. When you understand it and manage it, your surgery feels different. Faster healing, more stable bone, more stable tissue, fewer surprises. Biology always wins. Your choice is simple. Work with it or let it work against you. Thank you for watching. Please like and subscribe.